We are so excited to be here with the amazing Mr. Ian Holton. Thank you so much for being with us today.
Well, that's a pleasure, Tash. Always great to help and improve the education out there.
Yeah, and this is, so plastic surgery after bariatric surgery, I think is a unique beast. I don't think that it's just something that, I don't know, in my personal opinion, I don't think that everybody should do it. I think that we should leave it in the hands of very experienced people. And that is my personal view on that. And I would consider you one of those people. So thank you. We do appreciate that you're willing to talk to us about it.
Yeah, no, it's a pleasure, and I get it. People have the courage to realise that they've got to make a change in their life, and whether they do it naturally or with bariatric type surgery, they lose all this weight and it transforms their life. It removes conditions such as diabetes, blood pressure, all those sort of things. Their whole life changes, and they really have the courage and this well-being, but then they've left with the stigma with all the loose skin. So people come to us with this final part of the journey just to erase all the stigma. So people that have, they've done all the hard yards, everything like that, but they keep getting reminded, particularly if they look in the mirror, or get out of the shower, and also that psychological confidence, whether it's just how you dress, in the bedroom, whatever, that psychological well-being and the devil on the shoulder sort of undermining things. So it varies, it varies how well, how much weight you lose, how much, what your genetics are like, what age you are. But everyone has a slightly different list of what they want changed. It might be the stomach, might be breast, might be arms, might be neck, might be legs.
What do you see the most? What area of the body do you think people...
Tummy, because you get that the skin folds down and the mons pubic area drops down, and that has both physical and psychological.
We had to do mine 3 times, didn't we?
Well, we haven't come to there's a couple of hurdles, and problems we have with that, and we can talk about revisions, but and people get rashes where the skin folds over, and, and just, it doesn't matter, it might be a young person that's, in a new relationship, or it might be a grandmother wanting to take the grandkids to the beach, It's just that comfort of both physically and mentally being able to not have to worry about all the excess skin and that's theirs. Everyone varies in their what like done, but there's usually after a lot of a big weight loss, there's usually breasts and tummy in both men and women. And then variable amounts where the upper arms, people don't like the fact that, the arms get all loose and flappy and, But as we know, Tash, everywhere where the skin has been stretched and then shrunk, if you want to get rid of it, it involves a scar there. There's no way of doing it with non-surgical means. It's very, very rare to be able to do just liposuction where you don't have big scars. Unfortunately, where the loose skin and fat are, it means a big scar, and you can hide the breast and tummy ones, but things like the arms or neck or thighs. But I suppose I've been doing this 25 years. Really, the overwhelming comment when I tell people that is, people say, I don't mind the scars. That's a small price to pay for that.
I said that to you. I know I said that to you.
Yeah, everyone says it. Yeah, they accept it. Well, it has to be. It's non-negotiable. But just that correction of the contour. And the scars vary. Most people's scars are pretty good. They're pretty fine, and they're permanent. But they're usually white. It's rare to have red lumpy ones. Yeah. Yep. Yep. So
how do you manage people's expectations?
Education, and people have had forums such as Tash's have been fantastic because it's just really educating people. So most people these days, and this is the good side of social media, there's lots of not so good side, but this is a good side. People usually come in and they've done a lot of excellent research. So they have spoken to people who've had it, they've seen photos. These groups are just the transition or the crossing over and the swapping of stories and everything is really valuable for people's insight, because it's very easy for us in the medical side to be very medical about it. So it's good for people to have that sort of lay experience to explain things as well. So look, if we have a few red flags and we're worried about their expectations, then we need to see them lots of times. Or if they haven't done that outside education, then we feed them into that education so that they're well and truly educated on the risks and what to expect. And probably the number one problem for us with this surgery is the skin stretching again, because it has a memory of when you're at your maximum weight, and particularly if girls have had babies and their tummy's been stretched a few times with pregnancies, plus the weight loss, that skin always remembers that. And so the moment you pull it tight, it starts stretching, it gets on the move again and starts stretching. And that's unfortunately genetics, that's the body, that's the behaviour of skin. And so we always say that you've got to expect maybe 2-3 operations to just keep combating that stretching. And it varies from person to person and age and the amount of weight loss and all those sort of things. But that's not a complication, I suppose. That's just a problem.
Yeah, I think that you both, because Ian, just for those that are listening, Ian's nurse Natalie is in the room as well. Both Ian and Natalie really well informed me. I feel that you told me what to expect. You told me that I could expect that I would need to have multiple procedures, that it was not going to happen in a one and done kind of thing. And I was very grateful for that, because that was definitely my experience. I'm a stretchy girl, and I'm a stretchy girl.
And the modern person wants everything quickly and now and just once, where you have drive-in coffee, drive-in, we live in a very immediate world. And so one of the things, when you were asking before about Damo, about expectations, probably one of the not so well informed things is this expectation it's all going to happen in one go. People, and understand, people don't want to have multiple times off work. People don't want to go through multiple operations, but unfortunately it's a reality. It makes it a bit safer too. And there's things that, there's surgical considerations of multi-staging, like say if you want your tummy tightened, and you want your bottom lifted as well, I don't think it's a good idea doing them at the same time, because they're counteracting the forces. Like someone that has a bottom lift recovery, they've got to be out straight. They can't sit at 90 degrees because of the tearing force, which is what we exactly want people when they have their tummy done. We want them to be sitting at 90 degrees to take the force off to help with the healing. So we usually get a list of what people want, what areas, and we say, right, this is going to take 2 or 3 operations over the next year or two. We'll do arms and tummy, the first one, we'll do the breasts and legs, or whatever, we come up with a sort of a combination. And then at that second or third operation, if the area we did in the first operation is stretched, well, then we can retighten that as well. So we sort of, we just come up with a bit of a formula. And
I remember a few years ago when we'd started DSA, that we had a member at the time. They'd gone overseas and they had all of it done in one go. And this person was in so much pain, and it took them weeks before they could even come home because of the pain and everything that they were in. And she ended up leaving the group, which I understand as well, because it's sort of that constant reminder of the torture that she'd put herself through. I said to Tash at the time, I said, there is no way I'd recommend anyone ever have all their areas done at once. It's just a nightmare.
Well, it's a bit of a controversial area, the overseas surgery. There's some very excellent, very well trained, excellent surgeons in the Thailands and the Balis and everything like that, but you don't know the quality of both being able to communicate is such a key to this surgery, and talking through things, and there may be a language barrier. I think one of the fallacies is it's going to be a lot cheaper. It really isn't. By the time you do all the airfares and accommodation and everything like that, it really isn't that much cheaper. So I think that's a bit of a fallacy. You touched on the probably the most important thing is the aftercare. And it is this temptation, because you go there and you want to do it all in one go, you do too much. And this, like any surgery, this surgery has risks and complications. You can bleed, you can have clots in the legs, you can have pain, you can have all those sort of things. And if you go back to a hotel room or jump back on a plane, it becomes a real problem for the aftercare, and our patients generally aren't in a lot of pain. I think that's another fallacy. We find that people have heard of bad experiences with pain. It's usually not a painful operation, but if there's any aftercare or any problem or any issue, if you're a senior practitioner that's done the surgery and you've got access, and that's people have access to us, 24/7 for months and months and months and months after the surgery. And if they need it, great. If they don't need it, great. But you don't have that luxury with overseas surgery. And I think that's probably the main detriment. There's lots of people going overseas that have surgery and it goes well, but there's also lots where it doesn't go well. And I think there was something on TV last night about surgery overseas and this problem of aftercare.
Yeah.
And I think that's the thing, like you don't really hear about the cases where it doesn't go well because they don't want to talk about it. The people are still going through, and then they have all their issues to deal with once they are through it. And certainly the clinics aren't going to talk about it. And we do see that a fair bit in, with both weight loss surgery and with the plastics. Yeah, we sort of always encourage our members to go with someone local.
And we always encourage second and third opinions. Like if you've seen someone and you talk to them and you're still not, you don't feel totally comfortable with any aspect, including the costing, get a second opinion, get a third opinion. We always encourage people to, most fair and reasonable doctors are very happy to recommend someone for a second or third opinion. It's important that everyone is fully informed and fully comfortable.
So are there things that are unique, or would you say that there are increased risks for somebody that has had bariatric surgery, lost a lot of weight, and then they come around to having plastic surgery? Are there any things that people could be aware of or should be aware of?
If we talk about blood pressure and diabetes, they're the classic things. So most times when people have lost the weight, those things auto-correct.
Yeah.
Whether the body's totally corrected itself from a diabetes point of view, and the sugars might be okay, but that risk of infection and diabetes, does that completely go? So we usually give people lots of antibiotics, make sure the nutrition is that's one of the key things. So everyone that has had bariatric surgery needs a nutritional screen, because you don't know what trace elements might be missing, and you need to make sure the obvious ones are like iron for your hemoglobin and protein for your building blocks of healing, but anything from zinc, selenium, all these trace elements that are absolutely important for good healing, they need to be, full bottle to, as a preparation for the surgery. One of the other area that's a bit of a dilemma for us is when you're at your maximum weight, everything's big, including your blood vessels. So, this one, Tash, and so even if you might lose a significant amount of weight, the blood vessels tend to still be very big. And if people have been overweight for a long, long time and suffered, all the things like hypertension, diabetes, their tissues tend to be a bit fragile too. It looks, you can tell sometimes that the healing or the quality of the tissues isn't quite there. And so we're, as surgeons and the anaesthetists, we've got a dilemma. Do we give people blood thinners at the time of surgery because of the risk of clots, but then we've got these large blood vessels that we clip and we look out for, and we take very careful attention to make sure that they're properly tied off or clipped or anything. But these clips or things can pop, and if you're on a blood thinner to print, that increases the risk of bleeding. So that is a little bit of a dilemma for us, but once again, that's the aftercare. I mean, you had a bleed.
And what I will say is that,
I mean, that's what we're here for, and that's what that's what people expect in their care, and quite right. That's any fair and reasonable doctor knows that's their responsibility. And
I recovered well. Everything was fine. But obviously, it was at the time. Again, you had already discussed that with me prior. You'd already you told me about the risk of the big blood vessels, and I knew that was a risk. So
Yeah, and they're big wounds. They're big areas of.
how big was your, like, how long was your
My cut for my tummy tuck was 1 meter from hip to hip,
Wow.
and he took,
That's a whole lot.
it was like 4.8 kilos of skin, and it took me ages to recover from that. Like, I see these people and they're up, doing their tummy shots the day after surgery and stuff. I wasn't even out of bed. I was just like, no, go away, leave me alone. I was walking around like, hunched over for weeks. Yeah, it was.
But I was up the next day walking around.
Yeah, everyone's different. Culturally, there's some cultures that are just amazing. Like Vietnamese people seem to need no pain relief. They've got a remarkable pain tolerance, where other cultures, I won't say which culture, but there's other cultures where they need a lot. Or if people have had chronic pain for whatever reason in the past, because a lot of these people might have back issues from their weight. So they used a lot of painkillers in the past, and they've got a bit of sciatica. Then generally speaking, they need a bit more pain relief.
Yeah, that makes sense. I've had over 30 spinal procedures, including rods, screws, cage, 2 nerve stimulators, a few other things.
Nerves are like any other organ in the body. They have reflexes, and if you keep stimulating the reflex gets sharper and sharper and sharper.
I actually said to Tash the other week, I don't think that my pain tolerance is anywhere near it used to be. I just, it's like everything hits me a lot harder now. So, when you said about people with chronic pain, I was like, oh, that makes sense.
Yep. So, and we allow for that. We have that, but it's one of the weaknesses in surgery. Pain medication is far from perfect. We need these clever people to come up with new pain. Whether they're looking at finding pain medications from animals on coral reefs, or we need it because often the painkillers, treating the pain causes more problems than having the pain.
Yes.
Anything from nausea, hallucination, constipation, all sorts of things. So it's tricky, the pain. But generally speaking, with us, it's not too much of an issue.
We've had a question come in from the community, if you're okay for me to read that to you. This is from Charlotte, and she said, I hear that it's really important to see a plastic surgeon with extensive experience with weight loss patients, as our nerves and veins are different, as our bodies have settled in a different shape and size after many years of obesity. And seeing someone with experience without experience can cause higher risks with blood loss and complications. Is that true?
Yeah, I think as a generalisation, I think that's it's like anything in life, we always talk about putting an old head on young shoulders. I mean, experience is irreplaceable or incredibly valuable. So you just recognise when there's an issue or a problem or anything like that. And like when I was called in to see you, when you had your complication, I knew it straight away. And if I didn't recognise it, we might have left you and you might have kept bleeding and etc. So you just can't beat experience. And plastic surgeons, or anyone that's got a College of Surgeons fellowship, we've been trained extensively by that experience has been handed down by our mentors. And one of the key things in this whole area of plastic surgery, cosmetic surgery, this surgery, is that recognition of a complication and how to handle it. And that things can go wrong. Are you in the right place when it does, in the right place with the right person? So you are navigated through that complication, and part of the experience is the team too. I mean, you've mentioned Natalie, my anaesthetist, all the staff where we do it at St John of God here, Geelong. Everyone's experienced, so it's like a Formula One car team. Everyone has their job, the pit stop and everything like that. It just happens. It should happen seamlessly, and that because. Talking of speed, the quicker someone, the less time you're on the operating table, the less the risk. So if you've got multiple members of the team and moving quickly and knowing what they're doing and not foofing around and, being a bit in a dither or not knowing what's happening, then that increases the risk of problems. So I think Charlotte's question or statement is a valid one.
This is a very good question. How long do you recommend being?
Well, I think it's a safe thing, provided all those things like blood pressure and diabetes, you would allow for that, everything to settle down, and we would like to see it at least 6 to 12 months. But I think it's been taken out of our hands anyway because the government put a time frame. You've got to be plateaued at the weight. Is it greater than 6 months? I think the government stipulated in the Medicare schedule book that you've got to be plateaued at a weight for 6 months. So it's there in black and white now. So we have to abide by those Medicare rules. So one of the a good point talking about Medicare and rules and the issue of private insurance is an important one too, because if you're in private insurance, then if there is a problem or you need multiple operations, it's taken care of. It all just falls in, like personally in our practice, when there is a complication or a problem, there's no charge to fix or sort out. And I think a lot of plastic surgeons would do that. The problem if you're self-insuring, it's a riskier maneuver because there's that upfront cost of all the care and everything, and the care in the hospitals is expensive. But if you have a complication, then generally speaking now the private hospitals won't cover that. So there'll be extra costs after it. And you could have something unexpected, like you could have an unexpected allergic reaction to, say, the antibiotic, or you might get an infection, and if you're not in private insurance, then either you have to go into the public system to have that complication sorted out, or you have to pay again. And that's a really uncomfortable conversation to have with patients, because they're already paying a lot of money, and they're saying, well, if there's problems, there's going to be more. And so if people can, and this is with you back to your thing about how long should you wait, that also gives people the chance to get the qualifying period for the private insurance.
How do you, I think something that we do get asked a bit is, do I really need to stop smoking or alcohol before a procedure? How important is that?
Smoking is really important. There was an article in the Australian Journal of Anaesthetics, it must be over a decade now, showing that you had to be off the cigarettes for at least 6 weeks prior for any surgery.
Yep.
Just for your lungs to cope with the anaesthetic. Smokers get more infections, they get more bleeding, they get more wound breakdown. The complications are exponentially higher in smokers, and so most surgeons are pretty uncomfortable with anyone smoking for any operation, let alone this surgery. And if you're going to all the effort and expense, and you've turned your life around and your health around, then I know that cigarettes are very addictive and they're very hard to. And one of the things for weight loss patients they're always worried about is if they give up cigarettes, they'll put the weight back on. So this is a dilemma, a mental hurdle that they've got to get over, because really you've done all the hard work, you've lost all this weight, you've got your blood pressure under control, you've got the diabetes, but the smoking's going to be counterproductive for your long-term health. So we have a lot of people over.
To all those big incisions.
Oh yeah, and we have a lot of people that we insist that's a pretty non-negotiable thing. They have to really give up smoking, and over the years we've had a reasonable success. And people come back. I see them 20 years later, and they said, "Best thing I ever did was give up smoking." Well, it's not alcohol per se. If you have an alcohol problem, and you've got liver disease, which will show up on your preoperative screening of nutrition. People with liver disease from alcohol have clotting issues and bleeding issues. And usually nutritional too, the vitamin K, all those important building blocks for the clotting process. So if you're just a social mild drinker, then alcohol's really, you don't have to give it up months before, and you can have some after. It's not a big deal.
Can you explain the different approaches to skin removal and contouring, and how you decide what's best for each patient that you see?
Well, as we said at the start, Tash, there's what area worries that person. So once we've just made the decision that whatever area is the one to be fixed, then we generally show the patients by pinching the skin and showing what to expect, will be the contouring after by pinching. But we are in this two dilemmas. Is obviously we can't just keep pulling tighter and tighter and tighter, because if you pull too tight, you kill the skin. So there's only so much tightness you can pull out. And then we've got that real issue that we discussed before about the skin restretching. So it's a bit of a no-win situation. It's not worth pulling really, really, really tight, because then you're increasing the stretch more and more and more. So it's a no-win. You know, it's not worth keep pulling tight. But we show the people, and we try and show photos of people that are of similar ilk and size, and just to give them an idea of that's roughly what you'll end up.
Can I ask for fat transfer, because it's asked about a lot?
Yep.
A lot. Like I think probably with all the breast implant illness talk that's gone around for a long time, we get a lot of people asking in our plastic surgery group about fat transfers. My body seems to eat all its fat. Other people seem to have good success.
Yep.
Have you been able to narrow down what it is that?
No, this is one of the holy grails. Everyone around the world is working out when you can take fat and turn it from evil into good, and take it from where you don't want and put it where you do. And the classic is either the face or breasts are the two classic spots where it's amazing. It's just what in my time as a plastic surgeon, 20, 30 years ago, the thought if anyone said, oh, we're going to suck out fat and we're going to re-inject it, they would have been taken away in a loony, ambulance. It was just a bizarre concept where it's just become commonplace, and even Medicare have got an item number for fat grafting now. So they've even Medicare has caught up to it. So we realise that people's fat, we have stem cells in there, and I think this is going to be one of the next frontiers in medicine, is harnessing stem cells and healing by regeneration rather than repair. And stem cells, even doesn't matter what age or what part of your body, you have a certain percentage, 1, 2, 3% of in your fat stem cells with the ability to regenerate into whatever tissue you want. And so unfortunately, the TGA have shut stem cell research down in this country due to some bizarre complication in Sydney years ago. Unfortunately, we were doing a lot of stem cell work and getting amazing results, but the regulatory body didn't like where stem cell research, because once again, and it was happening all around the world, people that weren't properly trained or properly qualified were doing not so good things with people and causing problems with it. It wasn't, the stem cells themselves were excellent and the outcomes were excellent, but they just weren't used, or they weren't in the right hands. So fat has stem cells. So it really is a new frontier in our approach to issues. And the classic is implants versus fat for breasts. Implants do have problems. We don't think breast implant disease is true. There's been a lot of research in that. But implants do have problems. They can go hard. You do need a few operations where it'd be ideal to rebuild your breast volume and tissues with fat. But the problem is you can only do small amounts. It does get partly reabsorbed. One of the myths is that it always gets all resorbed. That's not true. Some people are better than others, as you said, and therefore you need lots of operations. Yeah.
No, but we should.
So I think that's the next holy grail. There are places around the world doing a lot of research on the use of fat, both in cosmetic and reconstructive surgery. In America, they use it. People with phantom stump pain, the war veterans that have had limbs amputated, they're putting fat in the stumps to take away the neurogenic stump phantom pain. We use it in breast reconstruction, women that have had mastectomies. We use it in facial trauma. It really is a new frontier. There is a lot of research going in of trying to lace the fat graft with your own stem cells to improve the take. That's what we're trying to. Evolving. Yeah, I'm sure it'll come, and it'll be it's a huge area. Unfortunately, our regulators, in their attempt to protect the public, have also put the brakes on advancements, which is disappointing.
Those of us that would just like to have a bit more boom.
And not use implants, and just use your own tissue. Yeah. That's a perfectly reasonable proposition, but it's not reality yet.
But Ian, what is your favourite part? Like, do Do plastic surgeons have favourite surgeries that they do?
Yes, yes. I mean, one of the beauties of plastic surgery is we've got such a broad song sheet. You know, we can be doing skin cancers, hand surgery, trauma, as well as the cosmetic surgery. So, and it's all interesting. You know, I still enjoy taking out a skin cancer off someone's face and reconstruct with a little flap and not only get rid of the cancer, but cosmetically it's barely detectable that they've had something done. I mean, that's, you know, I always remember my 90-year-old grandmother who had to have a skin cancer off her face and she was worried about the cosmesis, you know. So if we can juggle the need to get rid of the cancer but reconstruct without any stigma. But I think the pleasure we see with the bariatric patients when they, you know, I mean, just to look at the smile on your face, you know, and it's always a pleasure to see you, Tash, you know, and what we've been able to give you is just
Yeah.
made all the years of study and hard work and getting called into the middle of the night all just evaporates. It's all worth it.
I've thought long and hard. Would I go down the? My bum still looks like it slid down my back, and my thighs are still pretty bad. But I do have those great big blood vessels. So just that constant thing. I always wonder. Probably will see me back eventually.
The groups of patients that come back afterwards are the ladies, whether they're in their 20s or their 60s, and the breast reductions with the really big breasts, and they come back and they have a C or a B or a D or whatever size, and they just can't believe they don't have that weight on their shoulders, the back pain.
The pain's gone.
The pain's gone.
Yeah, absolutely. I think that's the beauty of what you guys do is you actually change people's lives in such profound ways. It's life changing.
And there's all the naysayers and the negative people and everything like that say, oh, it's unnecessary surgery and everything like that, but it's just a complete underestimation of the psychological well-being because you can't measure it, you know. And it's an interesting argument. I've been doing this 30 years. A child that comes in with ears sticking out, who's getting teased, you know, mercilessly at school, no one has any issue with those ears being pinned back. That is 100% cosmetic. You don't run faster or swim faster or anything like, or hear worse or anything like that. That is a cosmetic plus the psychological well-being. And you see that child's life, if you get to them early enough before the psychological scars of being terribly screwed. And we've seen the terrible sequelae of bullying at the moment in social media and young children taking their lives, you know. So we can see how crucial psychological well-being is. So no one has any argument with a child, but yet as an adult, whether it's big breasts, small breasts, you know, excess skin, whatever, you know, there's this negativity towards it. Labiaplasty, there's a lot of labiaplasty surgery being done these days, and it's getting, the naysayers are saying it's genital mutilation and all sorts of nonsense. You know, it's if a woman is both physically and psychologically worried about labia or anything, and it's worrying that particular individual,
That's right.
you know, our job as surgeons are, can we do an operation that's safe, low risk, you know, that will deliver that outcome you're after? There are extremes. If people are coming with really outrageous and they're fine, like we see lots of people coming in wanting stuff and we say, no, you're fine. You don't need anything, you know, and I think that's important. But if our job is not to be judgmental about the merits of it, and as I said, as Nat said before, the psychological well-being, the smile on people's faces after they've had any of this surgery is testimony to the fact that it is worthwhile surgery. And ironically, the naysayers, like it often is other medical practitioners and everything like that, there's this dichotomy that they fire the shots from the cheap seats, but when it comes to them or a member of their family that want it, all of a sudden it becomes worthwhile surgery. It's a very odd hypocrisy, but that's another story.
Thank you so much for joining us today. I think we've had an amazing time, and we hope we can do this again
very soon.
I'd love to. I like anything for education, and you know, and me. I know what it's like to be on the receiving end. Me or members of family have needed medical advice and help, and just that security and of knowledge and the power of knowledge, and just to make informed choices